It's the Pain Exam Podcast with your host, David Rosenblum, MD. If you treat pain or have an interest in pain management, join us as we discuss painful disorders, alternative treatments, practice management, and more. Be sure to subscribe to the Pain Exam newsletter at PainExam.com and review the podcast on Stitcher or iTunes. Our high-yield premium episodes are now available on the PainExam app with a premium subscription or access for free with a CME subscription at PainExam.com. And now, without further ado, here's your host, Dr. Rosenblum.
Welcome back to the show. Just got back from West Virginia, which, believe it or not, it would be quicker to fly to the Middle East. It took me 13 hours to get back. There was a delay, and it's 2 flights to New York with a 2-hour car ride, but it was worth it. It was an amazing experience. The Greenbrier Hotel, if you've never been to West Virginia, this is a crazy hotel. It's like Civil War era, I think. I don't know. Maybe it's 17 or 1800s. But there's a museum underneath, which is a bunker. I think the congressman used to, hypothetically use it in case of some sort of war as a place to seek refuge. Anyway, this place was really cool. Ran a course there for ultrasound. I was invited to teach ultrasound at Florida SIP and Florida State PM&R meetings in September. So if you're interested in coming to Orlando to meet me or just to come to a great conference, I'll run the ultrasound event. It's already on my website if you want to sign up. In Florida on September 22nd, that's a Sunday. In May, next month, I have a 2-day course, regenerative medicine on Saturday, ultrasound on Sunday, and I'm going to do more 2-day courses. I don't have anything planned yet after that May, but probably in the fall, I'm thinking maybe October time, give or take. There was a good response to that. I think a lot of people who come to New York want to come for more than just one day of education. And we try to finish early so you can go out and enjoy the day. What else? Aspen coming up. I'm going to be at IASP Mexican chapter meeting as faculty and lecturing and teaching ultrasound. So if you happen to, or if you want to go to Mexico City in August, I'll see you there. And just to be involved and stay in touch, I just submitted part of the guidelines to ACIP for peripheral nerve stimulation. So I've become familiar with. I'm writing with my partner Gary Schwartz the chapter on data synthesis of the shoulder, knee, and hip. And to be honest, I wish there was more data, especially the hip. The hip really has one case report that I could find, and actually I have an anecdotal case which I published on YouTube of a guy who had his hip operated on. I think it was a fracture, and he had chronic hip pain afterwards. And after trying multiple shots, which failed, I did a peripheral nerve stimulator, the Sprint device, on his superior gluteal nerve and a cluneal nerve, and he finally got relief. So it's making me think he probably has some sort of superior gluteal trauma or neuralgia related to his original injury or the surgery, which the PNS helped him with. So if you're not familiar with PNS, and if you're an interventional pain doctor, get familiar with PNS. It is the future. And present, I guess. But it really helps a lot of people. I've seen some home runs. I've seen failures, of course. But anyway, what I'm going to talk about today is a case I did yesterday. I have a patient with refractory shoulder pain. My partner would take care of her. She had her shoulder replaced. So this post-operative, post-shoulder replacement surgery. And she failed the suprascapular nerve blocks, any sort of, trigger point or tendon injection he could give her. He eventually did an ablation, a cryotherapy ablation of her shoulder, and that didn't work. So because he moved offices, she transferred to me, and I wound up doing the Sprint device, the 2-month PNS, and just as I mentioned, that device gave a home run for the other patient. It didn't do anything for this patient. And I've had home runs with post-shoulder replacement surgery with peripheral nerve stimulation. I've really seen it do amazing things, but unfortunately in her case, it didn't do a thing, and she's miserable, and she's a really nice woman. But having had, thank God, a short bout of shoulder pain in the fall after a trip, and I didn't really have much wrong with me on my MRI, but the incapacitating pain, the lack of sleep, inability to lie on your side. I mean, shoulder pain could be absolutely miserable, and a lot of us don't really appreciate this unless we suffer it. You could hear about it all day long, but unless you're feeling it, you really don't know. And hopefully you'll never know. But for those of you who do, right, it's miserable. So as a last-ditch effort, I offered her a radiofrequency ablation of the articular branches of the shoulder. I do not honestly have much experience with this, but it's definitely in my wheelhouse. I know how to use an x-ray machine. I know how to perform RFA. So after having some diagnostic nerve blocks that were positive temporarily, I decided to do the ablation. Of course, the fact that she had her shoulder replaced did make it a little bit more challenging. So I do have an episode of this on a previous podcast that I probably did at least a year ago. I don't even remember which episode. So if you look through my podcasts, I'm sure I have one. But I'm just reviewing. There's a really nice page. I'll put this in the show notes from Azra on the newsletter. How Do I Do It? Shoulder Articular Nerve Blockade and Radiofrequency Ablation by Maxim Eckert, Mihir Joshi, and Brittany Beckelhaupt. It's really a nice article. So it was written in 2020. They go over the innervation of all the muscles of the shoulder. I'm not going to regurgitate that. There's a chart here. It's actually quite long and detailed. So the degenerative shoulder diseases that they describe include cartilaginous injury, osteoarthritis, inflammatory arthritides, soft tissue disorders such as tendonitis, bursitis, tendinopathy, tendon tear, adhesive capsulitis, instability, and impingement disorders. And many times patients will have a mixed picture, right? It's not just one thing sometimes wrong with the shoulder because everything can affect everything else. They also mention nerve entrapment, especially suprascapular nerve. And in terms of treatment, like every other orthopedic condition, rest, NSAIDs, PT, steroid injections, maybe PRP or BMAC. Anyway, we have a lot of things to offer these patients, but when all else fails, like in this patient, what are you going to do? So the stimulator didn't work. The cryoablation didn't work. So I work at an AM Surge Center with lots of other pain doctors, and there's one pain doctor there who's been doing quite a few of these, and he's having some success, so I figured I'd try this. What we're doing here is we're targeting the suprascapular nerve, articular branch, axillary nerve, articular branch, nerve to subscapularis, and lateral pectoral nerve. The lateral pectoral nerve provides innervation to the acromioclavicular joint and associate coracoacromioclavicular and coracohumeral ligaments. The safe zones for ablations have been defined as lateral to the area of spinoglenoid notch posteriorly, this suprascapular branches, and the inferior posterior portion of the greater tubercle axillary branches, and then over the coracoid process, the lateral pectoral branches. And there's pictures of this. It's hard to kind of describe it. I think you really need to look at the link I'm sharing here and check it out. The lateral trunk of the suprascapular nerve could also be ablated, which may spare the supraspinatus function, but could compromise infraspinatus function. Midway between the suprascapular notch and spinoglenoid notch in the supraspinatus fossa, the nerve lies. The nerve to subscapularis should be accessible over the anterior superior neck of the glenoid. However, due to proximity of this nerve to the brachial plexus and axillary artery, preclinical and clinical work upon determining the ideal ablation trajectory is ongoing by the team involved in this study. And that was 4 years ago. This study was published, so hopefully they have more up-to-date data, which I've yet to find. So I warned the patient before doing this procedure. I said, you may lose motor function of parts of your shoulder. She said, I don't care. I don't have motor function now. I haven't had it for over 6 months, over actually a few years. So she can't even lift her arm up for like over a year. So if I could just relieve the pain and that would make her happy enough. Of course, we want her to have motor function. I don't want to ablate her nerves. So I'm looking at the pictures here. You have some nice view of the safe zones versus the motor and sensory zones. And once again, just study this on your own. Don't just do this shot. And like I did, talk to people who've done this procedure. It's quite valuable. And, I know there's a lot of anesthesiologists who don't do pain listening to this podcast. You never know. There's a possibility one day in the future you're going to be ablating nerves like this pre-surgery. I know the cryotherapy iovera device, they're doing a lot of preoperative ablations for patients. So you never know. You may be asked to ablate shoulder nerves prior to surgeries at sometime in the future. Who knows? Maybe not. But I know that the peripheral nerve stimulator companies are doing studies on managing postoperative pain with neuromodulation. So why not do it with cryotherapy as well, or radiofrequency ablation if it's safe and it helps the patient? And of course, if somebody's willing to pay for it, right? So I did the procedure yesterday. I'm going to share some of the images. It may not look exactly like Azra's images because A, she had her shoulder replaced, and B, once again, the patient's awake. We're stimulating, looking for paresthesias in the area of the shoulder joint and the targeted nerves, but not motor stimulation. So that being said, I try my best. She left there relatively happy as she could be. I'm hoping it really helps her because I'm running out of options. And if somebody out there has any other options that I did not try, I am all open to hearing about it because this woman is suffering. And like I said, I understand what shoulder pain is like, and it is no fun. It can be quite devastating and debilitating. Luckily for the shoulder, we do have a lot of options for it. So I am contemplating running fluoroscopic workshops, and I don't know the level of interest out there. I imagine it's big, but I think what would really help me organize this and move my butt to do this is if those of you out there emailed me. And if you're really serious about this, about coming to New York for a course, just like my ultrasound courses, I may either run a cadaver lab or find some sort of radiopaque spine models to use. And we could go over targeting the shoulder joint for RFA, spine procedures, etc. So please let me know via email, info@nrappain.org. You could get me there, or docrosenblum@gmail.com. That's BLUM. And if not, I hope to see you at my other courses. Of note, Ala Abdul El Said, who, if you don't know, he's probably one of the most prolific pain physicians out there. He wrote pretty much, I don't know, by now 50 books. This guy just doesn't stop writing books and publishing. Editor of Pain Physician Journal. He has a great conference in Wisconsin in August. Unfortunately, it's the same time as my Mexico City conference. So if you're near Wisconsin, go check out his conference. I know it's going to be amazing. This guy is nonstop educator, author, editor, etc. And on top of that, both of us did a live board review course a couple years back in Dallas, and that course is now available on the nrappain.org/PainExam website, where we have our pain management board prep. So you could purchase that with your board review membership. It's another set of hundreds of board questions that we go over in detail with the students at the lecture. It's a webinar format, so you could just watch at your own pace. And I think you'll find it quite useful in your studies for the boards. Anyway, thank you for listening. Once again, please share the podcast with people who you think might be interested. Please rate us in iTunes, Stitcher. This podcast, most of these episodes are not, I guess not, I was going to say not billable hours. I don't get paid for this. Every now and then I'll get a sponsor here and there, but for the most part, it's a labor of love. So if you could just share this with other people or review it or both, I would greatly appreciate it. And I hope to see you at the courses, either online or in person. Thanks for listening. Have a great day.
Dr. Rosenblum is here solely to educate, and you are solely responsible for all your decisions and actions in response to any information contained herein. These podcasts are not intended as a substitute for the medical advice of a physician to a particular patient or specific ailment. You should regularly consult a physician in matters relating to yours or another's health. You understand that this podcast is not intended as a substitute for consultation with a licensed medical professional. Copyright 2017, David Rosenblum, all rights reserved. No part of this publication may be reproduced, stored in a retrieval system, or transmitted in any form or by any means, electronic, mechanical, recording, or otherwise, without the prior written permission of the author.